أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Dear students, this is the screencast for pituitary gland pathology. I hope inshallah this will benefit you and you can use this screencast as one of the learning strategy. So this slide shows you what we expect from you to learn in the pituitary gland pathology, and in other words, we want you to do certain things after you finish this lecture. That is, you can be able to list the causes of hypopituitarism, and you can be able to describe the types and morphology of pituitary adenoma, and you can be able to correlate the histopathological features compare with the clinical feature, that is correlate with the clinical feature of various types of pituitary adenoma, and you can be able to explain the effect of craniopharyngioma on pituitary hormones, and you can be able to compare the hormonal profile studies pattern with clinical and histopathological features and arrive at a diagnosis. Okay, so you can compare the different clinical and histopathological features and with the hormonal profile studies to come to a diagnosis. Inshallah this lecture will help you. So before going to the hardcore pituitary gland pathology, let us discuss some basics. Okay, it's now I think you guys know more about basics. So let us start with hypothalamus. So hypothalamus is a part of brain, and it is composed of nerve tissue. Inshallah you'll be knowing more about hypothalamus in the CNS module. So now just you take it, hypothalamus is a part of brain, and it's composed fully of nervous tissue. So actually the role of hypothalamus in endocrine is, it is like a master which dictates the other gland. So this hypothalamus secrete and neurosecretory substances that controls the anterior pituitary and make or stimulate the anterior pituitary to release a hormone which will go and act on the another endocrine gland. Then the other endocrine gland will produce their final hormone. So this final hormone which goes and act on all the tissues or the targeted tissues, and thus they produce their function. So what you have to understand is this connection, this hypothalamus and getting connected with the pituitary and with other system, it is called hypothalamic hypophyseal portal system. These hormones are called neurohormones. It also may have stimulatory effect or inhibitory effect. So some call hypothalamus is the true master gland, okay, but some call pituitary is the master gland. However it may be, you have to understand hypothalamus is controlling the anterior pituitary. So anterior pituitary is under the control of hypothalamus. So now let us discuss about the pituitary gland. It's very small tiny gland, pea-sized gland, which located at the base of the brain, and it has two parts. The anterior pituitary we call, and another one is posterior pituitary, but we should know the other names of it, very important. It is called adenohypophysis. The anterior pituitary is called adenohypophysis, and posterior pituitary is called neurohypophysis. Posterior pituitary is called neurohypophysis. Because adeno means gland, the real glandular unit is in the anterior pituitary. Posterior pituitary is full of nerve tissue. It is just extension of the hypothalamus. So it's very important to know these facts. So let us see what are the hormones secreted by the anterior pituitary and posterior pituitary. So the anterior pituitary secretes growth hormone, adrenocorticotrophin hormone, thyroid stimulating hormone, and gonadotrophins like follicular stimulating hormone and luteinizing hormone, and they release prolactin, and one more hormone they release is called melanocyte stimulating hormone, which has close relationship with ACTH. Inshallah, that we discuss in the adrenal gland pathology. The posterior pituitary gland releases, see, it's not producing, it releases antidiuretic hormone and oxytocin. Understand? The antidiuretic hormone, inshallah, we'll discuss in detail, and oxytocin plays a major role in females. They are the responsible for secretion of milk, and the another major role is they play a major role in labor, child delivery, that is the contraction of the uterus. So let us discuss the normal morphology of pituitary gland. The normal gross appearance of the pituitary gland, actually, which is removed from the sella turcica. Sella turcica is a bony cavity where this pituitary gland, it is like a bed for the pituitary gland, and the larger portion of the pituitary gland is of anterior pituitary, and they have a stalk which is an extension of the hypothalamus. The inferior aspect of the pituitary is this one, and you can see this is the part which is called neurohypophysis or posterior pituitary gland. Let us see how they look in microscopy. What you are seeing, two different areas. Okay, so the area which has purple color cells along with pink color cells, and in between there are some cells which is not taking the color, okay, dull looking cells. But this area is totally different. Okay, so this is the area which is full of dark blue color cells, right? You see small dark blue color cells. These are all glial cells. This is posterior pituitary, otherwise called as neurohypophysis. So what you are seeing in this area, it is adenohypophysis. So adenohypophysis is the real glandular unit of pituitary gland. Let us see adenohypophysis in higher magnification. So just to show you guys the three different types of cells, you can see pink color cells, which is otherwise called acidophilic cells, and you can also see blue color or purple color cells, which is called basophilic cells. And there are some cells which are like little bit, they are not taking color, and they are called chromophobes because we mean it like they have phobia towards taking color. So these three looks in different in appearance by means of color, as well as they functionally differ. These acidophilic cells secrete growth hormone and prolactin. The basophils secrete corticotrophin, that is adenocorticotrophin hormone, thyroid stimulating hormone, and gonadotrophins, you all know, like follicular stimulating hormone and luteinizing hormone. The pale color cells are otherwise called as chromophobe cells. They have granules and they have secretory capacity, and they may secrete prolactin. So these are the three major cells which is seen in the anterior pituitary. They secrete different hormones. So now coming to the posterior pituitary, the higher magnification of posterior pituitary. So you don't see any such kind of cells, and you are seeing small dot, rounded cells, and even we call it as a roasted egg appearance. Inshallah, that we'll discuss more when we talk about the histology in the central nervous system. So this is posterior pituitary, otherwise called neurohypophysis. See, their role is just store and release ADH and oxytocin. See, they just store and release ADH and oxytocin because it is actually coming from hypothalamus. They are coming from hypothalamus. It's very, very important. So they come from hypothalamus and they get stored here, and they are released when it is needed, right? So it is just a storehouse. So now coming to the certain clinical manifestations seen in pituitary diseases. So pituitary diseases are like they can increase their hormones. It is called hyperpituitarism. So what causes them to increase more hormone, produce more hormone? One of the most commonest one is pituitary adenoma, and hyperplasias can happen, carcinomas of the anterior pituitary can happen. Sometimes, this is very, very important, the pituitary remains normal and the hormones comes from other areas, which is ectopic hormones, and usually it comes from the non-pituitary tumor we call, most probably from the lung. And remember, there is another condition called hypopituitarism. It reduces the hormone level, and it comes whenever the pituitary is damaged due to ischemic injury or surgically or radiation wise it's damaged, or due to immune reactions or inflammatory reactions. And this is very important. The adenomas may not secrete hormones, and they become big and they can destroy the normal pituitary, and the tumor also cannot secrete hormone. This will land up with severe hypopituitarism. That is decrease in the pituitary hormone. So Adenomas may be functional, non-functional. So functional adenomas will produce hyperpituitarism, non-functional adenomas will produce hypopituitarism. Okay. So however, whether they are functional or non-functional, if they have a, they are going to produce a mass effect, then they will produce certain characteristic signs. What are they? They are near to the pituitary gland, is near to the area which is connected for visions. Inshallah, that we will discuss more about what are the areas surrounding the pituitary and what type of tissue they are, how they are related with the optic nerve and optic chiasma and vision. Everything we'll discuss in the CNS module. And now just to take it, they will affect the vision, and it is called bitemporal hemianopsia, which means the side of the vision, that is lateral vision, is affected on both sides. Very simple. So it is called bitemporal hemianopsia, and it is the tumor in the inside the cranium, so it elevates the intracranial pressure, and the sign of intracranial pressure elevation is headache, nausea, vomiting. And pituitary apoplexy, it is like a sudden increase in the size of the pituitary gland. It is called sudden bleeding in the pituitary gland. It is called pituitary hemorrhage, acute pituitary hemorrhage, and it is called pituitary apoplexy. This can happen and they can produce mass effect. Remember, if anything happens to the posterior pituitary, anything happens to the posterior pituitary, okay, if it could be result in increase or decrease in secretion of ADH. Most of the times the ADH secretion is decreased if the tumor affects the posterior pituitary, or hypothalamus is destroyed by a tumor, or hypothalamus is destroyed by the tumor. So these are the various clinical manifestations. Okay, I hope you all got my point. And now coming to the hyperpituitarism, we'll discuss in detail now. And you all know that it is caused mostly by the adenoma. The two comes in the anterior pituitary. And remember, we classify this tumor on the basis of what type of hormone this adenoma releases. So what type of hormone they can release? They can release anterior pituitary hormone. So based on that, we name this adenoma. Very simple. If they secrete ACTH, it is called corticotrophic adenoma. If they secrete growth hormone, it is called somatotroph adenoma. If they secrete prolactin, it is called mammotroph adenoma. If they secrete both growth hormone and plus prolactin, it is called mammosomatotroph adenoma. If they secrete TSH, it is called thyrotroph adenoma. Or if there is some gonadotrophic secretion, it is called null cell or oncocytic adenoma. This is only the different name you have to study. So remember, these are the different types of adenoma they produce, and the adenomas can produce single hormone or two hormones. Two hormones, remember, most commonest combination is growth hormone and prolactin. And when you talk about adenoma, you should also remember the adenoma may be non-functioning. So we do a special stain that is called immunohistochemical demonstration of these hormones, and if they are negative, no hormone, we put all the hormone and we check. Actually, mostly we won't do that. Actually, we don't go for extensive exploration. We put only the commonest thing like prolactin like that, and we check whether they are there or not. If they are not there, then we consider they are non-functioning. And remember, they will not produce any clinical symptoms of hormone excess, which means they will not produce any symptoms related to the hyperpituitarism. If it is functional, there will be excess hormone and the clinical manifestation will be characteristic. So larger pituitary adenoma and they are non-functional, they end up with hypopituitarism because they destroy the normal pituitary gland, adjacent normal pituitary gland, and the whole pituitary will become full of adenoma. That adenoma is not going to produce hormone because it is a non-functional. If it is a non-functional, it will end up with severe hypopituitarism. Okay, so this is the concise table which shows what type of cells and what type of hormones they produce and what type of tumor they can come, and they end up in what type of syndrome. So if they produce it comes from the corticotrophic cells which they will secrete ACTH. It is called ACTH cell adenoma, and it can produce Cushing syndrome, and it can also result in Nelson syndrome. And if they come from the somatotrophic cells and they secrete growth hormone, it is called growth hormone cell somatotrophic adenoma, and it can produce gigantism in children and acromegaly in adult. So if they produce lactotroph, it comes from the lactotrophic cells and they produce prolactin, and they are called prolactin cell adenoma, and they produce this kind of symptoms like galactorrhea in the male and amenorrhea in the female and sexual dysfunction and infertility. And somatotrophic, mammosomatotrophic, or both the cells can be involved and they can produce prolactin and growth hormone. This adenoma is called mammosomatotrophic adenoma, and there will be combined clinical feature of growth hormone and prolactin. So thyrotrophic cells can produce TSH, and that is called TSH cell adenoma, and they can result in hyperthyroidism. So gonadotroph produce follicular stimulating hormone and luteinizing hormone, and they will end up with hypogonadism, like mass kind effect, and hypopituitarism. So these are the different tumors produce different effects. So now come to let us discuss certain very specific features of pituitary adenoma. Remember, it comes in the adult to the late adult age. They may be localized or it may be invasive. Then if they invasive, they erode cella turcica, and if it is very small in size, less than 1 centimeter, it is called microadenoma. More than 1 centimeter, it is called macroadenoma. The most commonest one is prolactin, followed by growth hormone producing adenoma. And remember, the ACTH adenoma is very dangerous because they can have high chance to become cancerous, malignant. And now coming to the Nelson syndrome, let me explain here. Okay, now let us take a condition. The person is of 50 years of age and he had some renal cell carcinoma, and that renal cell this is adrenal gland. Renal cell carcinoma is involving adrenal gland, and this is the same situation happened. This renal cell carcinoma spread here, and it is also involving the adrenal gland. What then they will do? They remove this kidney and the adrenal gland. Now when they remove this kidney and the adrenal gland, the hormones of the adrenal gland will be reduced because there is no adrenal gland, right? What happens? That will immediately produce the positive feedback on the pituitary. Now the pituitary glands goes for hyperplasia and they secrete ACTH. Okay, when they secrete ACTH, the ACTH has to go and act on the adrenal gland, but there is no adrenal gland here. So the ACTH are released, but there is no end hormone, so there will be strong positive feedback again, and they secrete more and more and more and more ACTH. So in the end they go for more hyperplasia, and in the end they results in adenoma. Okay, so this is called Nelson syndrome. Okay, so this is called Nelson syndrome, and TSH producing adenoma are rare or very rare. So let us discuss the morphology of pituitary adenoma. So this is the very large pituitary tumor. See, it is compressing the surrounding brain. This will produce massive visual abnormalities and intracranial pressure. What you are seeing in microscopy, this adenoma is, see, it is all looking same type of cell, monomorphic appearance. So it is called cellular monomorphism. It is characteristic feature of pituitary adenoma. Usually there should be like this. There should be like this, like 3 different colors of cells should be seen. Now you are seeing full of pink color cells. It is nothing but cellular monomorphism, and this is another characteristic feature of pituitary adenoma. Now coming to the hypopituitarism. Hypopituitarism refers to, you all know, decreased secretion of pituitary hormones. Remember, I am going to give a criteria here. If 75% of the parenchyma is lost, okay, or absent, then the hypofunction symptoms comes into the, in other words, it can be detected. So 75, if you see a person is having syndromes or symptoms or signs related to hypopituitarism, if you think in that perspective, which means 75% of the gland is already destroyed or lost. So keep that in your mind. So if the posterior pituitary is having dysfunction, and it will result in a disease condition called diabetes insipidus. Okay, inshallah we'll discuss that more. So what are the causes for hypopituitarism? So first you should remember about a emergency situation called pituitary apoplexy. It is a sudden bleeding happens into the pituitary gland, often occurring into the pituitary adenoma. So the bleeding happens into the pituitary adenoma and destroy the pituitary. So now coming to the Sheehan syndrome, and it is called postpartum necrosis of the anterior pituitary. Understand, the posterior pituitary is not affected. So the blood vessels involved in the anterior pituitary is affected. So mostly after the labor, after the child delivery period, the female goes for anterior pituitary necrosis that results in a severe hypopituitarism related to the anterior pituitary hormone. It is called Sheehan syndrome. Now coming to the empty cella syndrome, that is in the cella, in the MRI you will be seeing no pituitary gland. Okay, it is a serious condition. And now coming to the hypothalamic lesion, there are some tumors comes in the hypothalamus or tumors surrounding the hypothalamus can destroy the hypothalamus. They end up with serious deficiency of this ADH, results in diabetic insipidus. So what are the clinical manifestations they can produce? They can produce in children growth failure because of no growth hormone, and if there is no gonadotrophin, they results in amenorrhea and loss of libido and impotence, and secondary characteristics of female will be disappeared, and infertility in women. So if there is deficiency of TSH and ACTH, it is very, very important, because if hypothalamus or hypopituitarism happens, especially related to the anterior pituitary, see, the ACTH is not there, there will not be cortisol. If there is no cortisol, they go for severe hypoglycemia, and it confuses with diabetics. And if the person is a diabetic and is having hypoglycemia, and so you will suspect usually the person's drug is causing the hypoglycemia, but he may have some hypopituitarism also. So you have to link the things with other clinical features and to come to a conclusion. Now prolactin deficiencies leads to the postpartum failure in the postpartum lactation. So remember, anterior pituitary is also a rich source of MSH, okay, synthesized from the precursor molecule, the parent molecule that also produces ACTH. So the person may become paler due to loss of melanocyte stimulating hormone on melanocytes. Now coming to the two important clinical condition, that is called diabetic insipidus and syndrome of inappropriate ADH secretion. So diabetic insipidus, it is due to the decreased ADH and a condition characterized by the increased urination due to inability of the kidney to resorb the water because there is no ADH. It may be due to central cause, that is due to pituitary, it is called central diabetic insipidus. Or there might be some problem in the renal tubules which they cannot be able to reabsorb the water, that is called nephrogenic diabetic insipidus. What happens is the water is going out in the urine and the sodium is getting increased, that results in change in the osmolality. As a result of excessive renal loss of water, that results in thirst and polydipsia. So now coming to the syndrome of inappropriate ADH secretion. Okay, remember, if there is too much of ADH, what happens? They reabsorb too much of water, and that will dilute the sodium level, that results in hyponatremia. Most often times we suspect ectopic ADH, that also we suspect cancer in the lung, especially small cell carcinoma of the lung, which is commonly seen in the smokers, whether they smoke cigarette or shisha or any other stuff related to the tobacco. So severe hyponatremia leads to cerebral edema. Actually this part we gave as a homework. So what it happens is the hyponatremia is happening rapidly because of increase in the water level. So there is decreased sodium because of increase in water. So what happens is the sodium, this happens in the blood. So the sodium in the interstitium, in the intracellular space and in the intracellular, their level is increased. So automatically that pulls all the water, and that results in more increase in total body water but not in the blood. So that's why there is no peripheral edema. Okay, so the total body water is increased but blood volume remains normal. So this is the thing you should understand, and that is a problem in syndrome of inappropriate ADH secretion. So now let us conclude with a tumor in the hypothalamus which is called craniopharyngioma. If this tumor comes, that destroys the hypothalamus, that results in diabetic insipidus. Because hypothalamus is destroyed, that will decrease the ADH. So if you know this, it is enough. This is all for actually pathology curiosity. Like it is a different types of craniopharyngioma exist. Some are common in children, some are common in adult. Whatever it may be, if hypothalamus is destroyed because of tumor coming in the hypothalamus, or the tumor surrounding the hypothalamus can compress the hypothalamus, they can compress the hypothalamus. If anything happens to the hypothalamus, automatically it will decrease the it will decrease the what ADH, that results in diabetic insipidus. So in diabetic insipidus, the more water is reserved, what happens? The more water is going in the urine because there is decreased ADH. So it cannot be resolved. So automatically what happens? The sodium concentration level shoots up. So keep that in your mind. So this is about anything happens to the hypothalamus which results in diabetic insipidus. So this ends the lecture, and these are the learning resources. I strongly suggest you guys to read this book. If you can't read this book, another suggestion I can give you is use Pathoma. Okay, Hussein Sattar is doing good job there. You can use his book. Masalama.